Hello, my name is Folashade Jayoba. I'm here to present my stakeholder education plan. I will be talking about the plan and also my stakeholders and the theoretical foundation and conceptual framework that I'll be using. And I will also be talking about the plan and implementation of my project. Prescribed treatment and medication compliance is necessary in the management of both negative and positive psychotic symptoms of schizophrenia patients. This stakeholder education plan is prepared to educate and train stakeholders who will be involved in the clinical scholarly project plan to measure the cost of effectiveness of integrating non-pharmacological intervention like spiritual care in the treatment of persons suffering from schizophrenia in order to increase medication adherence rate within 3 months. This CSP is keen on incorporating in clinical setting non-pharmacological interventions such as spiritual care with pharmacological interventions to create a holistic plan of care that will result in an effective quality treatment plan for the patient. The value of bringing in a significant spiritually oriented psychotherapy for schizophrenia patients in a clinical setting cannot be underestimated. The following stakeholders will be involved in this project: well-trained physician, psychotherapist, nurse practitioner, social worker, spiritual counselor, clergy, and administrative staff in the area of spiritual and religious care. The plan is to provide individual therapy and/or group sessions. The physician and nurse practitioners will conduct thorough and brief spiritual assessment in order to identify spiritual needs. Once spiritual needs are identified and prioritized, resources on local faith communities, spiritual reading materials, information on and referrals to religious organizations or groups or other facilitators of religious processes will be provided to the patient through a collaboration with the nurse practitioner and the social worker. Mike Cox, Milner, and Rusinova, 2012. The social worker will see to it that the patient gets all the resources available, including the services of a spiritual counselor or clergy, who will also comprehensively assess and clarify spiritual needs and develop a spiritual care plan to address those needs. Since spiritual needs are often closely linked with social issues, the chaplain or spiritual counselor will also collaborate with the social worker. There will be a follow-up to ensure that spiritual needs are met and feedback provided to the clinic. The administrative staff will coordinate appointments, availability of materials, and overall running of the office clinic. The theoretical foundation and conceptual framework that will be used for this CSP is the health belief model, in which medication compliance will be seen as a behavior for improving the patient's health status. Health belief model serves as an organizing framework to explore the relationships among perceptions of illness severity, susceptibility, benefits and barriers of treatment, cues to action, and medication compliance. The result provide a systematic description of health beliefs reported by psychiatric patients. Kelly, Mammon, and Scott, 1987. When patients have no knowledge of their illness or medications, their symptoms are usually difficult to manage. But when non-pharmacological interventions such as spiritual care is introduced, patients find opportunities to learn about and cope with their illnesses and treatment regimen. The health belief model is applicable and useful for psychiatric patients as they perform specific behaviors, such as taking their medication to get over their mental illness. Seal and Main, 2005. This will enhance a broad understanding of attitude of patients' medication and treatment compliance. The implementation plan, part of this plan, is going to involve three phases. The first phase is an in-service training where providers, physicians, psychotherapists, and nurse practitioners, and the social worker will be trained to develop self-awareness and familiarity with the religious and cultural beliefs of the cultures of the individuals they will be serving. Also, training will be provided to develop the awareness of their beliefs, comfort levels towards religious issues in therapy, and developing understanding of the risk and benefits of psychotherapy for people with schizophrenia. At the end of the training, the providers will assess whether they have the ability to respect the spiritual and religious beliefs of clients with schizophrenia and refrain from coaxing their own religious beliefs on the patients. Stakeholders will be told about the value of the project, how they will be kept informed of the progress of the project, and how they can help to facilitate the project. In the second phase, providers will explore the patient's religious goals and activities that will be supportive of the recovery. Relative resources during their talk therapy sessions. The Hope Questionnaire, which examines dimensions of hope, organized religion, personal, spiritual practices, and effects on medical care, will be used. Mixoc, Milner, and Rusinova, 2012. In this phase, providers will use emphatic questioning and listening to explore the patient's motives and meanings of spiritual and religion. The provider will also engage the patient in a collaborative process to ask about when and how the patient would like religion, spirituality to be included in their care and their life. Day 2009. Additionally, providers will take a spiritual history, examine changes in faith and levels of commitment, core religious and spiritual beliefs, religious activities, rituals, and spiritual life, relation of spiritual life to goals of well-being. Finally, and the third phase is going to be a follow-up and evaluation of the plan. This is when the provider uses information gathered to connect to appropriate resources in therapy. This can be done during an individual or group session. Patients will be evaluated at follow-up sessions for compliance with recommended pharmacological and non-pharmacological interventions. A number of positive outcomes have been identified specifically for individuals with schizophrenia surrounding their religious and spiritual beliefs, yielding implications for therapy indicated that positive outcomes are generally associated with positive religious coping, the affirmative religious beliefs and practices for coping with schizophrenia. Boras et al. 2007. And this ends my stakeholder plan, education plan. And thank you very much for listening and have a good day.